Nice to be here this Sunday morning with all you to discuss the cardiac imaging and heart failure. I would now like to introduce my friend, Dr. Prabhu, who is a consultant in multi-specialty hospital at Chennai and very active member of API, the Association of Physicians of India. And he has very special interest in diabetes and hearts, anything to do with heart and diabetes. So we've given him the topic, Dr. Mahapatra, the role of system MIBI in heart failure, that is MIBI, the nuclear technique. Over to Dr. Prabhu.
Thank you, Dr. Prabhu, for your kind words. In fact, Dr. Mahapatra has asked me to speak on MIBI scan. Probably it is a SPECT CT on heart failure. I'd like to share this particular slide. And since it was a couple of days ago, my colleague, Dr. Manohar, referred this gentleman to our department with the exertion dyspnea chest pain. This is a classical feature what we often come across when a patient is present to us with heart failure. When we do a myocardial perfusion SPECT, what we see is a hugely dilated ventricle with a grossly hyperperfused inferior wall and an ejection fraction of 25% during stress, and subsequently it is improves during rest images. We just keep it in mind. With this background, we have to appreciate why this is very important. Because the incidence of heart failure is quite increasing these days. In India, a couple of years ago, when the paper was published, it shows us that rheumatic heart disease is very commonly prevalent. That is in North India. And in southern part of India, it's more like a Western economy, which is developed, where the ischemic heart disease is more commonly prevalent. And we also recollect the newer terminologies that are coming up. That heart failure with mildly reduced ejection fraction, heart failure with normal ejection fraction, and all put together anything EF above 40 to 80%. It is a normal ejection fraction or a preserved ejection fraction. New terminologies are coming up. We should also appreciate with the new developments in guideline-directed medical therapy or the device therapies, the previously classified as reduced ejection fraction is now getting salvaged. It has become moderately improved ejection fraction. This is the new terminology that is coming up. And mid-range ejection fraction. These are the things that are coming up. And as nuclear physicians, we have to catch up with it. We also remember that heart is not just made up of cardiac myocytes. There are a lot of neuroendocrine cells, fibroblasts, telocytes, and all these things are also contributing. But then the volume of the heart is made up of only cardiac myocytes. Grossly, what happens is whenever there is increasing challenge to the heart muscle, it gets hypertrophy. If it is a proportional hypertrophy during physiological hypertrophy, there is increased length and width of the myocytes as such. Whereas if it is a pathological hypertrophy, there will be expression of new cardiac contracted proteins. And this can be arranged in series, which causes eccentric hypertrophy, or it can be arranged in parallel, which causes concentric hypertrophy. When we go deep further, we have to appreciate further, because this is a level of understanding what we have in nuclear medicine. Hypoxia triggers anaerobic glycolysis, and this causes accumulation of hypoxic inducible factor 1 alpha. This reduces the pH of the mitochondrial milieu, and it disrupts the mitochondrial membrane and decreases the ATP secretion. Ultimately, it enhances the reactive oxygen species level, increases cell death, and all these things is what we are going to see in nuclear imaging. And to some extent, what we'll be dealing, and my colleague Dr. Mahapatra will be leading the rest of it in PET imaging. So what is the indication for a myocardial perfusion SPECT in heart failure? One is to assess the ischemic myocardium and the global and regional variability in left ventricle, to assess the LV function in regional EF thickening, wall thickening, reduction ejection fraction volumes, and all these things. We also assess the left ventricle eccentricity. We also, more important, we can appreciate the LV dysynchrony. And because of the device therapy, we can always identify the last available segment to contact. This is possible in myocardial perfusion SPECT. A lot of technology has given up new modern semiconductor detector and solid-state gamma cameras, which give a very high resolution of images. This is what today we are talking about. We are extensively using system MIBI. This is a tracer which diffuses across the cell membrane, gets deposited into the mitochondria. And this is proportionate to the distribution of the coronary blood flow. And the ideal tracer will be oxygen-15 labeled water, and for which we need a medical cyclotron. And I'm sure that only Dr. Gambhir is capable, because he has a very dynamic functioning cyclotron in his department. And the newer molecule which are yet to get is the fluorinating flupridase. And we are just eagerly waiting for getting this molecule. But otherwise, for all practical clinical purpose, we are extensively using the system MIBI. And this is what happens. Once it is injected, it goes passively diffused into the cytosol and gets localized into the mitochondria. And there is a proportional washout. It is retained in the mitochondria for a prolonged period of time, and it doesn't get redistributed, unlike thallium. And there are other traces like myovu, terbroxime, and there are new traces which have 8 times affinity into the mitochondria. There are certain traces which have more rapid clearance from the liver cells, and there are traces which are more stable even after 24 hours. What we are to remember that we are to look after the washout rate of the system. This out we take the heart to mediastinal ratio, and whenever there is a heart failure, there is expression of P-glycoprotein. This particular protein is responsible for the newer drug resistance in cancer therapies and TB and all, and it is expressed more in hepatocytes where there is very rapid washout of system MIBI. This is how the normal myocardial perfusion study looks like. We can see that it's almost uniformly thickened, and we can see that the ejection fraction is 79 to 80%. And when comparatively, when a patient with similar clinical condition, what we see is a grossly dilated ventricle. We can see the perfusion deficit in the excluding stress and rest images in the anterior wall territory. From 12 o'clock to 3 o'clock is the circumflex artery territory. From 3 o'clock to 9 o'clock is the RCA territory. Almost from 12 o'clock to 8 o'clock, it is LED territory. And we can see the grossly dilated ventricle with decreased ejection fraction during stress and rest. For all practical purposes, we prefer doing pharmacological stress and as a 2-day protocol in our institution. While using pharmacological, we commonly use adenosine as the standard protocols as prescribed by several studies. And sometimes we do get patients like this where the ejection fraction is decreased at rest and improves during stress images. And some patients we get ejection fraction deteriorates in stress images with the minimum LV dilatation. We advise some sort of intervention, whether it is a CABG or a stenting, whatever may be the procedure. What we found out that it definitely improves the outcome in the longer run. We do occasionally get some patient with a grossly dilated right ventricle. The LV function is almost normal, almost exactly normal. But what happens is, this is a grossly dilated right ventricle we do come across. And when we say that this RV is larger, that means it is definitely larger than the left ventricle. And it is commonly seen in pulmonary hypertension, heart failure, valvular heart disease, ischemic heart disease. And what is the significance of this? Earlier speaker, Dr. Satish Govin alluded that right ventricular functional abnormalities are definitely what you call is quite serious. So it causes twice the mortality of the left ventricular dysfunction than normal right ventricular function. In diabetes, the cardiac muscles is overloaded with lipids and glucose. As a consequence, the efficiency decreases. There is increased accumulation of free fatty acid, atheroma formation, reactive oxygen species formation, and there is decreased oxygen influx. There is decreased ATP production. As a consequence, it reduces. There is a decreased mitochondria, and the contractile function decreases in the longer run. And there are a lot of meta-analysis have been done when comparing the patients with diabetes without diabetes. It found that heart failure is quite severe in them, and this is what it is. When compared to the normal patients, in heart patients with diabetes with IDDM and NADM, IDDM was more severe and more heterogeneous distribution, and is definitely far superior than the other contemporary imaging modalities. There is, if you want to appreciate LV dyssynchrony, like this happened, this patient we saw a couple of days ago. What happens is the QRS complex is greater than 120 milliseconds, and we can see that there is a lot of functional abnormality, and this patient was definitely benefited by CRT. There are certain special situations, like especially in women in heart failure. WISE study, women study, so many studies have come up which say that women have atypical symptoms, epigastric discomfort is there, nausea, radiating pain, all these things will be there. And there are high-risk markers for stress for cardiac SPECT. When the sum stress score is greater than 8, when there is abnormal myocardium greater than 10%, and there's a LV dilatation, despite of peak stress, the LV ejection fraction remains less than 45%. And these are the algorithm by which we can work out on a patient in a women with a suspected heart failure. There are a lot of evidences that have been evaluated, and with a strong recommendation appropriateness, what we have found out there, what has been suggested, that whenever there is a suspicion of heart failure, the SPECT CT and the SPECT PET myocardial perfusion imaging is more appropriate. And so is the other conditions like in valvular heart diseases where there is severe systolic dysfunction and LV diastolic dysfunction. SPECT MRI, SPECT PET, and all these things are very appropriate for investigations. These are the various cardiac guidelines. Academic bodies have been periodically issuing guidelines depending upon the evolving science and the technology, and this has been almost uniformly followed throughout the world in various centers, and so that the practice of nuclear cardiology is uniform. With these few words, we can also recollect that infiltrative aortic disease because of amyloidosis. This can easily be routinely done in a clinical setup by doing pyrophosphate scan, and we can see the degree of infiltration, which is a major cause of heart failure in many patients. And there are a lot of guidelines by Dr. Sharmila Dorbala and her team and how to go about the evaluation of cardiac amyloidosis, because we don't, in the first place, suspect amyloidosis in our clinical practice. And whenever there is a strong suspicion, this is how we are going to evaluate. And it helps us to identify heart failure long before it can get clinically manifested. There are a lot of meta-analysis with comparing CMR, cardiac expectant PET, and these are the evidences, and it shows that technetium-99m pyrophosphate imaging has a higher degree of specificity, and SPECT CT is a better degree of performance. Not only that, it is ease of doing the procedure, ease of the patient, and availability extent everywhere. This helps us to identify cardiac amyloidosis in a much better manner. There is something called as autonomic innervation imaging, in which we will be able to do in MIBG by doing routine MIBG scan. 123 iodine is not available in our setup. I tried to do with the 131 iodine, but then the images are not as good as what we could get in 123 iodine. What happens is there should be a perfect balance between the parasitic and the parasympathetic and the sympathetic stimulation of the heart, so as to ensure that the heart rate, blood flow, and contractility is maintained. And MIBG is an analog of norepinephrine, which is resistant to metabolic enzymes, and it has a high degree of affinity for norepinephrine transporter. This is what happens. The tyrosine yields dopa yields dopamine, and this is exocytosis. Through this, norepinephrine is liberated, and these are the receptors, and these receptors are expressed to a varying degree in a failing heart. And this is the response. This is responsible for the early washout in patients with heart failure. And we'll be able to quantify the retention of MIBG for a prolonged period of time when the patient is having normal heart. And when a severe heart failure, there is early washout, which helps us to prognosticate what could be the possible prognosis. What will be the prognosis that can happen? And for this, we need not withdraw the beta blockers, AC inhibitors, ARBs, SGLT inhibitors, or ARNIs, which are routinely using for the management of heart failure. This is the ADMIRE HF study. In this study, the MIBG was evaluated serially for a prolonged period of years, and it was found out the patients who are able to retain MIBG in their heart for a prolonged period of years, they have a good prognosis. Whenever there is a rapid washout, there is increased incidence of arrhythmias. So what could be the cause? Probably there is increased sympathetic innervation, which causes increased washout of the MIBG, and as a consequence, there is decreased heart uptake, heart to mediastinal ratio, and this predicts atrial fibrillation, hypertrophic hypertrophic cardiomyopathies, cardiotoxicity due to chemotherapeutic agents and all. So MIBG not only helps in imaging the extent, but also helps us to risk stratify the patient. The challenge is in a grossly dilated heart, it is difficult for us to anatomically localize where exactly the borders are. Then there are a lot of data that are being thrown up. We are not here to challenge which modality is superior, which is going to be the one single modality, because every modality has its own principle, has its own strengths and weaknesses, and also availability in a particular institution. The level of expertise available in this particular institution varies from varies. As a consequence, all this huge amount of data, we need deep learning and artificial intelligence for handling a huge volume data. And as a consequence, we'll be able to handle this and be able to identify a subclinical heart disease long before they get clinically manifested. In fact, the myocardial perfusion study helps us to understand the preserved ejection fraction. With patients more than 50% ejection fraction, because these are the majority of the patients we come across in our practice. And the multimodality imaging is going to be the rule of the day, and it helps us to find out the varying degree of heart failure in diastolic dysfunction. Cardiac aspect not only helps us to understand the HPF, HTF, and also the amyloid infiltration, and MIBI cardiac aspect helps us to predict the heart failure and optimize expensive treatment strategies that are evolved, especially in device implantation and all. And deep learning and artificial intelligence is what going to be the rule of the day in future. Thank you very much.
Thank you, Dr. Prabhu, for that lucid overview on use of SPECT and MIBI and other technetium agents for the use in the heart failure.